Hi, welcome back everyone. Now let's discuss one of the most clinically important ECG topics, myocardial ischemia and infarction, followed by several miscellaneous ECG changes that are commonly tested on the MCCQE exams. We'll begin with ischemia. Ischemia occurs when there is reduced blood flow to the myocardium. On the ECG, ischemia is primarily identified by ST segment depression and T wave inversion in the leads overlying the affected area. As ischemia progresses to myocardial injury and infarction, the ECG changes become more dramatic. In transmural infarction, where the full thickness of the myocardium is affected, the hallmark finding is ST segment elevation in the leads facing the infarcted region. This is what we recognize as an ST elevation myocardial infection or STMI. In contrast, subendocardial infarction involves only the inner layer of the myocardium and usually presents with marked ST segment depression rather than ST elevation. These ECG findings are often accompanied by elevated cardiac biomarkers such as troponins, confirming myocardial infarction. Let's now look at the evolution of the ECG changes during a myocardial infarction. The earliest ECG change is often hyperacute T waves. These are tall, broad, and symmetrical T waves that appear within minutes of coronary artery occlusion. Next comes ST segment elevation, representing acute myocardial injury. This change usually develops within the first few hours. As the infarction progresses over hours to days, pathological Q waves may appear, indicating irreversible myocardial necrosis. Finally, over days to weeks, the T waves invert, reflecting myocardial reperfusion and healing. Months later, the ST segment usually returns to baseline, while Q waves often remain permanently, serving as evidence of a previous infarction. Let's review the criteria for significant ST elevation. ST elevation should be present in at least two contiguous leads. Generally, an elevation greater than 0.1 millivolt or 1 millimeter is considered significant in most leads. However, leads V2 and V3 require higher thresholds, especially in younger men, because mild ST elevation can be a normal variant. Now let's discuss pathological Q waves. A Q wave is considered pathological if it is more than 40 milliseconds wide, deeper than 1/3 of the total QRS amplitude, and present in at least two contiguous leads. Remember that Q waves represent myocardial necrosis and often persist long after infarction has healed. Next is localizing the infarct. The ECG leads tell us which coronary artery is most likely involved. Septal infarction affects leads V1 and V2, usually due to occlusion of the left anterior descending artery. Anterior infarction involves V3 and V4, also supplied by the lateral LAD. Anterolateral infarction affects leads 1, AVL, and V3 through V6. Inferior infarction is seen in leads 2, 3, and AVF, most commonly caused by right coronary artery occlusion. If right ventricular involvement is suspected, obtain right-sided leads V3R and V4R. Posterior infarction produces reciprocal ST depression and tall R waves in V1 and V2, since the posterior wall is not directly visualized on the standard 12-lead ECG. Being able to match ECG leads with coronary artery territories is a high-yield examination skill. The figure on the right demonstrates atrial enlargement. Left atrial enlargement produces a broad notch P wave in lead 2, often called P mitral, and a biphasic P wave in V1 with a prominent negative terminal component. Right atrial enlargement produces tall peaked P waves in lead 2 known as P pulmonale and a tall initial positive component in V1. A brief note on pacemakers. An atrial pacemaker creates a pacing spike immediately before the P wave. A ventricular pacemaker creates a pacing spike before the QRS complex, producing a wide QRS complex that resembles a left bundle branch block. Finally, let's review several electrolyte disturbances. Hyperkalemia first produces tall peaked T waves. As potassium rises further, the P waves flatten and disappear, the QRS widens, and eventually the ECG develops the classic sine wave pattern, which is a medical emergency requiring immediate treatment. In hypokalemia, we see ST depression, flattened T waves, prominent T waves, and QT interval prolongation, increasing the risk of torsade de pointes. Hyperkalemia also increases sensitivity to digoxin toxicity, making recognition especially important in clinical practice. So, in brief, ischemia equals to ST depression and T wave inversion. Acute transmural myocardial infarction equals to ST elevation. Old myocardial infarction equals to persistent pathological Q waves. Localized infarcts using contiguous ECG leads. Hyperkalemia causes peak T waves and widened QRS complexes. Hypokalemia causes flattened T waves, prominent T waves, and prolonged QT interval. Remember, mastering these ECG patterns allows rapid diagnosis of myocardial infarction, localization of coronary artery occlusion, and recognition of life-threatening electrolyte abnormalities, skills that are essential for both MCCQE examination and everyday clinical practice. Calcium abnormalities. Calcium primarily affects the QT interval on the ECG. Hypercalcemia shortens the Q interval because increased extracellular calcium shortens the plateau phase of the ventricular action potential. In contrast, hypocalcemia prolongs the QT interval by lengthening the plateau phase of the action potential. A useful memory tip: high calcium equals a short QT, low calcium equals a long QT. Hyperkalemia. Now let's discuss hyperkalemia, one of the most important electrolyte emergencies. The ECG changes progress as serum potassium rises. Initially, patients develop tall, narrow peak T waves, especially in the precordial leads. As potassium continues to increase, the PR interval becomes prolonged. The P wave becomes flattened and may disappear. The QRS complex widens. Eventually, the QRS and T wave merge into the classic sine wave pattern, which is a pre-terminal rhythm and may rapidly progress to ventricular fibrillation or asystole. Remember, peak T waves are the hallmark of early hyperkalemia. Hypokalemia. In hypokalemia, the ECG findings are almost the opposite. Typical findings include flattened or inverted T waves, ST segment depression, prominent U waves, which appear after the T wave and are the classic sign of hypokalemia. Severe hypokalemia also increases the risk of ventricular arrhythmias, especially torsade de ponta. A simple way to remember this is low potassium produces low T wave and large U waves. Hypothermia. As body temperature falls, several ECG abnormalities develop. Sinus bradycardia is the most common finding. In more severe hypothermia, both the QRX complex and QT interval becomes prolonged. Patients may develop atrial fibrillation, ventricular arrhythmias, or other conduction abnormalities. The classic ECG finding is the Osborn J wave, also called the J wave. This appears as a hump-like positive deflection at the junction between the QRS complex and the ST segment. Whenever you see a prominent J wave, always think of hypothermia. Pericarditis. In pericarditis, the ECG changes occur in stages. In the earliest stage, you will see diffuse ST segment elevation affecting many leads, PR segment depression, upright T waves. Unlike myocardial infarction, the ST elevation is widespread rather than confined to one coronary territory. Later, the ST segment returned to baseline, followed by flattening and eventual inversion of the T waves. Patients may also have mild sinus tachycardia due to pain or inflammation. A helpful memory tip is diffuse ST elevation with PR depression strongly suggests acute pericarditis. Let's move on to digitalis, or digoxin. At therapeutic level, digoxin produces the characteristic digitalis effect, which includes scooped or sagging ST segment depression, flattened or inverted T wave, shortened QT interval, prominent U wave. Slowing of the ventricular response in atrial fibrillation. Premature ventricular contractions are the most common rhythm disturbance. At toxic level, digoxin become high arrhythmogenic. Patients may develop paroxysmal atrial tachycardia with AV block, which is considered classic for digoxin toxicity. Severe bradycardia, junctional rhythms, frequent PVCs, ventricular tachycardia, complete heart block. Clinical symptoms of toxicity includes nausea and vomiting, fatigue, confusion, visual disturbances, particularly yellow or green vision, known as xanthopsia. Also suspect digoxin toxicity in patients taking digoxin who presents with gastrointestinal symptoms and new arrhythmias. Other QT prolonging drugs. Several medications can also prolong the QT interval. These includes amiodarone, quinidine, phenothiazines, tricyclic antidepressants, antipsychotics, some antihistamines, certain antifungal medications, and some antibiotics. QT prolongation increases the risk of torsade de ponta, a potential fatal polymorphic ventricular tachycardia. Let's move on to pulmonary disorder. In pulmonary disorder, Uh, the first thing comes is cor pulmonale. It's a chronic lung disease, especially the chronic lung disease, especially the COPD, can you cause cor pulmonale, leading to right heart strain. Typical ECG finding includes right axis deviation, poor R-wave progression across the precordial leads, right atrial enlargement, right ventricular hypertrophy with a strain, multifocal atrial tachycardia, which is commonly associated with COPD, massive pulmonary embolism. In massive pulmonary embolism, the most common ECG finding is sinus tachycardia. Patients may also develop atrial fibrillation or atrial flutter, right axis deviation, right ventricular strain. The classic but relatively uncommon ECG pattern is S1Q3T3, which consists of a deep S wave in lead 1, a Q wave in lead 3, an inverted T wave in lead 3. Although this pattern is highly suggestive, it is present in only a minority of patients. Let's highlight the key points. To conclude, hypercalcemia equals to short QT interval. Hypocalcemia equals to long QT interval. Hyperkalemia is equal to peak T waves progressing to a sine wave ECG. Hypokalemia is equal to flattened T waves with prominent U waves. Hypothermia is equal to Osborne J waves and bradycardia. Pericarditis is equal to diffuse ST elevation with PR depression. Digoxin is scooped ST depression at therapeutic levels, multiple arrhythmias when toxic. Pulmonary embolism, sinus tachycardia is most common. S1Q3T3 is classic but uncommon. Once again, mastering these ECG patterns allows you to recognize life-threatening conditions rapidly and confidently, making them indispensable for both examinations and real-world clinical practice. Now let's discuss a very practical method of ECG interpretation known as the PQRSTU approach. Instead of analyzing the ECG by disease, this method follows the normal sequence of electrical activity through the heart. If you understand this sequence, ECG interpretation becomes much easier. The mnemonic PQRSTU stands for P wave, PR interval, QRS complex, ST segment, T wave, QT interval, and U wave. Let's go through each component. Number 1, P wave, atrial depolarization. The P wave represents atrial depolarization, which is the electrical activity that causes the atria to contract. Normally, the P wave is rounded and smooth, less than 120 milliseconds in duration, less than 2.5 millimeters in height, best seen in lead 2 and V1. In lead V1, the P wave is normally biphasic, with a small positive portion followed by a negative portion. Several abnormalities can be recognized from the P wave. A sawtooth P wave suggests atrial flutter, typically with atrial rates around 300 beats per minute. An absent P wave with an irregular rhythm suggests atrial fibrillation. A tall peak P wave greater than 2.5 millimeters indicates right atrial enlargement, also called P pulmonale. A broad or notched P wave, especially with a prominent negative component in V1, suggests left atrial enlargement, also known as P mitral. 2. PR interval. PR interval, or AV conduction. The PR interval measures the time from beginning of atrial depolarization until the start of ventricular repolarization. It reflects conduction through the atria, the AV node, the bundle of His. The normal PR interval ranges from 120 to 200 milliseconds. A prolonged PR interval greater than 200 milliseconds indicates delayed AV conduction. Examples include first degree AV block, where every P wave is followed by a QRS complex, but the PR interval is consistently prolonged. Second degree Mobitz or Winkelbach block, where the PR interval progressively lengthens until a beat is dropped. Second degree Mobitz, where the PR interval remains constant but intermittent QRS complexes are present. Third degree or complete heart block, where atrial and ventricular rhythms occur independently due to complete AV dissociation. 3. QRS complex to ventricular depolarization. The QRS complex represents ventricular depolarization, the electrical event that triggers ventricular contraction. Normally, the QRS duration is less than 120 milliseconds. A widened QRS may indicate bundle branch block, ventricular rhythm, hyperkalemia, pre-excitation syndrome. The QRS complex should also be assessed for voltage, access, presence of pathological Q waves, and R wave progression across the precordial leads. 4. ST segment, or early ventricular repolarization. The ST segment begins at the J point, which is the junction between the end of QRS complex and the beginning of the ST segment. Normally, the ST segment is isoelectric, meaning it lies on the baseline. Important abnormalities include ST elevation suggesting acute myocardial injury or STMI. Significant ST elevation is defined as at least 1 millimeter in 2 adjacent limb leads, or at least 2 millimeters in 2 adjacent precordial leads. Horizontal or downsloping ST depression usually indicates myocardial ischemia. Always evaluate ST changes beginning approximately 60 milliseconds after the J point, as highlighted in the figure. 5. T wave, ventricular repolarization. The T wave represents ventricular repolarization. Normally it is upright in the most leads, is smooth and asymmetric. The abnormal T wave includes tall peak T waves seen in hyperkalemia, inverted T wave suggesting ischemia, previous infarction, or ventricular strain. Flattened T waves, which may occur in hypokalemia. 6. QT interval. The QT interval extends from the beginning of the QRX complex to the end of the T wave. It represents the total time required for the ventricular depolarization and repolarization. Because the QT interval changes with the heart rate, we use the corrected QT interval, or QTC. A prolonged QT interval increases the risk of torsade de ponta, a potentially life-threatening ventricular arrhythmia. The common causes include certain medications, electrolyte abnormalities such as hypokalemia or hypomagnesemia, congenital long QT syndromes. And that's it. So, 7, U wave. Finally, the U wave is a small deflection that follows the T wave. It is often absent in healthy individual but becomes prominent in hypokalemia, bradycardia, and some antiarrhythmic drug effects. A prominent U wave is an important clue that electrolyte abnormalities may be present. When interpreting an ECG, always examine each component systematically. Start with the P wave, measure the PR interval, evaluate the QRS complex, inspect the ST segment, assess the T wave, calculate the QT interval, look for a U wave if present. Using the PQRSTU approach ensures that no important ECG finding is overlooked and provides a structured framework for identifying arrhythmias, conduction abnormalities, ischemia, infarction, electrolyte disturbances, and other cardiac disorders. Mastering the normal ECG first. Once you know what normal looks like, recognizing abnormalities become much easier. Now let's continue our systemic approach to ECG interpretation by discussing the QRS complex, ST segment, T wave, QT interval, and U wave. Understanding these components allows us to recognize life-threatening cardiac conditions quickly. QRS complex. The QRS complex represents ventricular depolarization, which leads to ventricular contraction. The first thing to assess is the heart rate by ensuring that the RR interval corresponds appropriately with the PP interval. Next, evaluate the amplitude of the QRS. Increased voltage may indicate left or right ventricular hypertrophy. Then assess the duration. A normal QRS duration is less than 120 milliseconds, indicating that ventricular activation is occurring normally through the His-Purkinje conduction system. A wide QRS greater than 120 milliseconds suggests abnormal ventricular conduction. The causes include bundle branch block, ventricular hypertrophy, cardiomyopathy, Wolff-Parkinson-White syndrome, ventricular ectopic beats, hyperkalemia, and certain medications such as tricyclic antidepressants and antiarrhythmics. Now let's discuss the Q wave. The Q wave is the first negative deflection of the QRS complex. Small septal Q waves are normal and are commonly seen in leads 1, 2, 3, AVF, AVL, V5, and V6. A pathologic Q wave is the one that is more than 40 milliseconds wide or deeper than 1/3 of the total QRS amplitude. This strongly suggests myocardial necrosis, either from a previous or an acute myocardial infarction. Finally, abnormalities in the R and S waves often point toward bundle branch blocks or intraventricular conduction abnormalities. ST segment. The ST segment extends from the end of the QRS complex to the beginning of the T wave. It represents the period when ventricular depolarization is complete. And under normal circumstances, it should lie on the isoelectric baseline. Abnormal ST segments are extremely important. ST elevation is classically associated with acute myocardial infarction, but remember, there are several important different diagnoses. A useful mnemonic is I help a pale. This includes I for ischemia with reciprocal changes, H, hypothermia causing Osborn waves, E, early repolarization, L, left bundle branch block, P, post-myocardial infarction, ventricular aneurysm, A, acute STMI, P, Prince-Metal or vasospastic angina, A, acute pericarditis, and L, left or right ventricular aneurysm. Now consider ST depression. ST depression usually reflects myocardial ischemia and may indicate NSTMI if accompanied by myocardial injury. However, ST depression might also occur with reciprocal changes during STMI, left or right ventricular hypertrophy with strain, bundle branch block, Wolff-Parkinson-White syndrome, previous myocardial infarction, or non-specific ischemic changes. Remember the mnemonic worship to recall the differential diagnosis of ST depression. T wave. The T wave represents ventricular repolarization. Normally it is upright in most leads, except AVR and sometimes V1. Changes in T wave morphology provides important clinical clues. Inverted T waves may indicate myocardial ischemia, bundle branch block, ventricular hypertrophy, pulmonary embolism, or medication which affects such as dioxin. Tall peak T waves are classically seen in hyperkalemia, although they may also occur in hyperacute myocardial infarction. Flattened T waves are commonly associated with hypokalemia, pericarditis, pericardial effusion, or dioxin therapy. Another important concept is T wave alternance, where T wave amplitude changes from beat to beat. This finding indicates electrical instability and may precede ventricular tachycardia or ventricular fibrillation. And finally, understand T wave discordance. In bundle branch block, the T wave normally points in the opposite direction of terminal portion of the QRX complex. If the T wave is instead in the same direction as the QRS, this inappropriate concordance raises concern for ischemia or myocardial infarction. QT interval. The QT interval measures the total duration of ventricular depolarization and repolarization. Because the QT interval changes with the heart rate, we usually calculate the corrected QT or QTC, most commonly using Bazit's formula. A normal QTC is approximately 360 to 450 milliseconds in men, 360 to 460 milliseconds in women. A prolonged QT interval significantly increases the risk of torsade de ponta, a potentially fatal polymorphic ventricular tachycardia. The causes include congenital long QT syndrome, antiarrhythmic medications, antipsychotics, certain antidepressants, macrolide antibiotics, electrolyte abnormalities such as low potassium, low magnesium, and low calcium, hypothyroidism, hypothermia, and cardiomyopathy. Conversely, a short QT interval less than 360 milliseconds is uncommon but increases the risk of ventricular fibrillation. The causes include hypercalcemia, digoxin, and hyperthyroidism. U-wave. The exact origin remains uncertain, but is thought to represent repolarization of the Purkinje fibers or delayed ventricular repolarization. U waves are usually small, best seen at a slower heart rate, and occur immediately after the T wave. A prominent U wave is most common associated with hypokalemia, but it may also be seen in digoxin on antiarrhythmic medication. An inverted U wave is abnormal and may indicate myocardial ischemia or ventricular volume overload. Let's highlight some points. When interpreting an ECG, don't simply recognize patterns. Understand what each waveform represents. Physiologically, evaluate the QRS complex, ST segment, T wave, QT interval, and U wave in a systemic manner. This structured approach improves diagnostic accuracy and helps identify life-threatening cardiac conditions such as myocardial infarction, electrolyte disturbance, conduction abnormalities, and malignant arrhythmias. Thanks for watching. Please don't forget to like and subscribe. See you in the next videos. Bye-bye.